Hello, good afternoon. Welcome to the afternoon symposium session. My name is Amma Appiah. I'm a Regional Medical Director for Patient Engagement at ViV Healthcare, and I've been given the privilege to chair this session. And the session is called People First Language, Why is it important? So I have an amazing agenda. Hopefully you'll be able to participate and be really interactive. So the first part I'm doing, so I'm introducing, and then the second part we'll have Yvonne Gillies, who will tell us a little bit about why it matters that we should use people first language, and we'll have a discussion with Angelina Namiba, who needs no introduction today, especially, and Marvelous Michenje, who's also from ViV Healthcare, but has a background in community, who's coming with her own perspective. Within this, we're going to have QR codes that link to our feedback mechanisms and polling, so please make sure you have your phones out ready. So I've already introduced the panel, the faculty, and then these are our declarations. As I've said, I'm representing ViV Healthcare, but Marvelous is representing her own opinions, not necessarily ViV Healthcare. Okay, so people first language, why is this important? And you may already be using this, you may already be familiar, but essentially people first language is putting people before their condition, making sure that we're not using dehumanizing language that can lead to discrimination and stigmatization and leaving the person feeling resentful and dismissive of the care that they've received. So things like the way that we speak, the terms that we use when speaking to or about people is so important. So terms have been developed over time. This is nothing new. This has been around for the last 50 years, where there have been congresses where they have talked about the best language that we should be using. So instead of diabetic person, person with diabetes, instead of homeless person, person experiencing homelessness, and especially in this setting, instead of HIV-infected person, a person living with HIV. So, first question for you, and you may have seen this already with our table and our banners. From the QR code, giving you time to get your phones out and take a picture of the QR code, you can respond to this question. What we'd really like to know is what non-people first language you have experienced or encountered. Second thing we would like you to do is think about... Oh, sorry. Sorry, give you more time. So when you come to this question and you're taking, when you manage to get onto the app, really think about what you've encountered, the terms that you've heard. No matter how uncomfortable they are, we will come and discuss them later in our discussion session. Okay. So on your tables, you may have noticed you've got little speech bubble-shaped pieces of paper. What we'd really like you to do is think again about the association with the words and non-people first language that might have on people living with HIV. So while we're speaking, you might want to think about some feelings or emotions that might bring up and write them down, and we'll give you more instruction with what to do with that later on. But in the meantime, I'm going to ask my panelists if they can share their thoughts about the associations with non-people first language. So Yvonne, would you like to go first?
So I'm going to start with HIV-exposed uninfected infants, and I just find this very negative language. I don't have a foolproof other alternative, but I could suggest HIV-exposed and negative. And maybe this is something we could think about as a group, but certainly for me, this term feels very negative, and it doesn't feel like it really has a proper use in 2024. So that would be, for me, the one thing I would like to try and move forward on.
Absolutely. Angelina?
I've got down HIV victims. Victims, because you tend to hear a lot of people referred to as victims or sufferers. So I just think that belittles people and puts them in a position whereby they they're not humans, they're just victims, they're not fully participating members of society. So I think I would like to get rid of that. I can't think of a term to use just now, but definitely victims is one I really do not like.
And Marvelous.
For me, one word that really annoys me, it's not a word, actually, full-blown AIDS. It leaves me wondering, is there a half-blown AIDS?
Partly.
And clean and dirty. Oh, I'm clean, or I'm dirty. So does HIV makes me dirty? So those two are the ones that I've just put. And I put victim. I think great minds think alike.
Thank you so much. And I also neglected to point out that also with us, joining us on the faculty is our artist, Katia. So Katia is a live artist from Sketch Effect, and she's going to be actively listening to our conversations and pulling it to art. And you can have an opportunity to have a look at the art at the end and tomorrow. But also the carrot is if you do our feedback, then you can put your email address and you can get a copy of it sent to you. So please do make sure you're filling the feedback. So with that, I'm going to hand over to Yvonne.
Thank you, Emma. So why does people first language even matter? So words do have power, and I think it's really important to remember that. Language can make a difference. So we talk about sticks and stones can break my bones, but words can never hurt me. That is not true. Words can be incredibly damaging. And so what we need is neutral, non-judgmental words that are based on fact, actions, physiology, biology. We need words that are based on strengths, that are respectful, that are inclusive, and that impart hope. We need words that are free from stigma. We need words that foster collaboration between patients, between providers, and first and foremost, we need words that are person-centered. So when did this all start? So advocates living with HIV began in 1983, so that's over 40 years ago. The Denver Principles were published. So these were in the very early days of HIV, where a group of activists came together to provide recommendations on language when seeing somebody with HIV for use by healthcare providers, for use by all people, and also for use by people themselves living with HIV to be able to communicate. They also called for their inclusion in all decision-making about their health at this time. In 2012, the IAS Journal published an article suggesting that mother-to-child transmission as a terminology should be put out of use and instead be replaced with vertical transmission. There was also the suggestion that elimination not be used because it sounded quite violent, a violent act towards women living with HIV. And then in 2021, following another IAS conference, the People First Charter came together. So Laura Waters founded this. I'm a member of the steering group, as are a number of people in this room. And what we are doing is we are calling on policymakers, researchers, conferences, journals, care providers to follow guidelines and examples of best practice using recommended terminology, which is available online. It is by no means complete and will continue to evolve as we change how we address language. So I'm pleased to say that over time we have a number of HIV organizations, congresses and journals who have begun to accept and declare themselves as adopters of People First language. So I'm chair of the British HIV Association in the UK, and we use this language, we recommend it, as do our sexual health fellow organization, BASH, so British Association for Sexual Health and HIV. IAS support us, as do the European AIDS Clinical Society. Viva's journal and EAC's journal HIV Medicine supports this, as do the Lancet HIV group of journals. And we also have other congresses such as CROI, we have Pharma, so ViV have adopted this, as have Gilead. So this is a growing movement, and it is going to take time for it to get to the point where we feel our work is done, because it will continually evolve, and there are lots of old language being used in protocols, etc., and in journal articles that are still coming through that we need to address. So what does People First language mean for women living with HIV and for the wider HIV community? Well, we would argue that the HIV field is rife with terms laden with stigma and blame. So where we use terms such as HIV-infected, AIDS, I love the idea of half-blown AIDS. I'd never thought of that. I wish that's just brilliant, marvellous. It is marvellous, marvellous. And people who inject drugs, again, it is very stigmatizing language. Spreading HIV, catching HIV, and we've talked about mother-to-child transmission. So there are alternatives that are coming through that are available that we would really love for people to think about using. So a person living with HIV, a person with an AIDS-defining illness, because you can be well again after that. People who inject drugs or misuse substances. People can transmit HIV, HIV can be acquired, but the whole idea of infection can feel very damaging to the person who acquires HIV and where HIV may be transmitted. And I've talked about vertical transmission. And we know what women already living with HIV experience additional stigma. They can experience a lower quality of life because of healthcare providers who may not feel able to provide care or are quite ignorant about HIV. They may experience a poorer level of care. They have worse internalized stigma as a woman living with HIV. And overall, we know mental health issues such as depression and anxiety are more common in women with HIV. In the community where HIV is known about, there can be an impact both on that woman but also on her family as well, and that can result in a withdrawal of community support, a loss of reputation, and can even result in job loss and loss of income. So this is a big deal, and it's something that is pervasive in everything that happens for women living with HIV day to day. So I'm going to hand back to Amma now, where we're going to look at the Slido and see what's happening with your terminology that you don't like. Amma, do you want to comment on this?
Yeah, so I'm seeing it come up now, and hopefully it's on the screen as well. So we wanted this opportunity to ask you about these words, and we contemplated the fact that this might feel uncomfortable. It may make people feel quite discomforted by these words. But the thing is, we needed to face these words and confront how we feel about them so that we can overcome them. So the first discussion I would definitely like to say, I mean, seeing these words, it is quite striking what people have said and the terminology. Just to ask some of our panelists exactly what this is, the thoughts that they've had and the language that they have experienced and encountered through your work, through your life experience, through the work that you do.
I guess for me as a healthcare provider, I think with non-people first language, I think the first thing to remember is we need to be kind and non-blaming if we're trying to explain to somebody what language is about, because not everybody understands or means to cause, they certainly don't mean to cause harm. And I think it's important to remember that. So if you are trying to educate somebody about language that maybe you're encountering amongst your colleagues, in your hospitals or in your primary care centres, it's really important to try and do it with care and kindness. But for me, I think it's a learning process the whole time, because every individual may have a different way about how they want to speak about their HIV. And so it's about listening to every person that I see and working and trying to use the language they use, because that's important that I hear them and they know that they've been heard and I use the language that they want to hear. So that's probably the main thing I would take away from person-based language.
I think there's also a number of acronyms that have come up, and I know this is a striking one for you, Angelina. So, for example, PWIS, FWIS, AGW, I mean, is this person first language or is it not?
I don't think it's personal first language. I mean, I understand sometimes when people are writing papers and abstracts, they need to kind of have a word count. And so inevitably, they will have to reduce words to abbreviations. But I think, first of all, using the whole time, you know, adolescent girls and young women, or people living with HIV, you know, people who inject drugs, I think it's really important to just be able to spell out as the person as they are. But, you know, there are a few other words that, I mean, I'm really struck by some of the words that have come up, but there are a few others that I don't see on the screen there. Maybe if I could touch on a couple of them, would that be okay? Mm-hmm. So one of the first, I call it my pet hate, one of the terms that is used all the time is the term disclosure. This is used by both people living with HIV as well as health and service care providers. And I know, as Yvonne has already said, people don't often use these terms to be negative, but actually that's the term we use all the time. But if you think about it, the term disclosure is heavy, it's legal, legal, and it is very loaded. If I say to you, Amma, I want to disclose something to you, what are you going to think? It's a big thing. It's this big secret that I want to tell you. And instead, we always say, just tell people I want to share something. I want to tell you something that some information that I have. If you say share, tell, talk about it, it's the same thing that you're going to do, but it comes across very differently. That is just one of the terms that I think is really important that we start to change the way we use. There is another term which we use a lot, again, lost to care. I think you'll hear this used a lot, lost to care. The thing is, this is a term that is referring to human beings. We're not a set of keys or a piece of paper that is lost. So I think by doing that, you place all the onus and responsibility on the person who is not engaging in care. So it's really important to look at, why is this person not engaging in care? What can we as service providers and healthcare providers do in order to engage them? And I'll just touch on one last one, and this is a really interesting one. We tend to refer to people living with HIV in relationships as a serodiscordant couple. The only thing about these people, again, another negative term, is that one person is living with HIV, the other person is not living with HIV. So there's nothing discordant about this couple. In fact, I don't really know many words, good words that start with dis, apart from disco. Disco is a good word.
For me, the non-adherent or non-compliant is also an issue. Because sometimes it's not us who are fighting against the treatment, it's the treatment that's fighting against us. So trying to find ways of how maybe I'm having challenges with taking my treatment. So if you say I'm non-adherent, it feels like there's something wrong with me. But also, when I look at some of the languages that are put there, they come from our academic backgrounds. Like, for example, risk behavior. In public health, risk behavior is something that's used, but that also tends to, even risk behavior, when it's associated with sex, people don't want to talk about sex because it's a risk behavior. It's seen as a risk behavior, rather than looking at sex as something enjoyable or something that we can talk freely, because it's already termed in that way. It's a challenge. So some of these words came when those days, like one word that I didn't see there is skeleton. So when people were losing weight, they were thin, that came into mind. So that has also an impact. Even when we're talking about weight gain, you always don't want to go back there to being a skeleton, because you don't want to be seen as an AIDS victim.
I was just going to comment, Marvellous, on your comment about risk behaviour, and I think, the comment about people being promiscuous, it just takes me back to medical school. Now, I went to college in Dublin, so very Catholic Ireland, a very old style obs and gynae teacher, and he's talking to a group of 19-year-olds or 20-year-olds, and he's asking us the definition of promiscuous. Somebody said promiscuous, about promiscuous behaviour, so he stops and he goes, define promiscuous. He looks around the room. So everybody looks away, please don't ask me, please don't ask me. So he looks, and eventually he gets no answer. He goes, I'll tell you the definition of promiscuous. He said, promiscuous is somebody who sleeps with more people than the person asking the question. Because no one ever presumes that they are promiscuous. And that's probably the one of the major things I remember from my medical degree. I do remember a bit more. I just want to talk about the failed treatment, because I think that as well is really awful, because people do not fail treatment. Treatment fails people. And I think that's so important, that when we're presenting at conferences, when we're trying to share information, which is really important to share, that we just remember to say it in a way that isn't blaming. So for me, I agree, whoever put in failed treatment, because that's come up a couple of times. That's another biggie for me.
I'm going to move us on, if I can. So we've already just kicked into this panel discussion, but before we go into further discussions, I think there's another question we would like to ask the audience. So we'd asked you, what are your experiences with People First Language, and how can we get people to use People First Language? So if you are already in the app, or if you want to take the picture again, I'll give you time to do that. whilst I ask the panel again. So we've already sort of touched upon what our experiences are. I think the question I was going to ask was, how can we get people to use People First language?
So for me, even when we're doing our check-in for our presentation, Angelina says something, like the disclosure. That's something that never occurred into my mind, that it can be a negative word. So unless you have awareness of what a word means, like for example, if you ask someone about racism and you expect them to automatically know that they are actually experiencing oppression or racism, they might not. So it starts off with the awareness. So when we talk about even people, especially as people living with HIV, we might have used those words to protect ourselves. Like to feel like I own it. For years I've been saying, me and my HIV. And then someone says, is it your HIV? Did you develop it or manufacture it? But it was a way that those words, we use them as a way to fight against HIV. So when we are saying, how do we get people to use the language, we have to educate them. We have to raise awareness. Even within AIDS safe organizations, sometimes we're comfortable saying that language amongst ourselves. But then if we tell some people to say change it, but they're hearing us saying the words, so it's difficult again also to change it. And acronyms are so familiar in HIV. So some people might choose, oh, I might just changing this one. What about these other ones? So for me, I think it starts with awareness and willingness, and also raising why is it like that. And then maybe we can learn also from other diseases. I realized when I was just looking, the disability sector has got so much that has happened, so maybe you don't need to reinvent the wheel. It's just taking how did they manage to get to that point? How did they include legislatures? Well, sometimes it needs also changing policies, because I talked about public health. If I'm coming in as an immigrant, the first document I'm getting is a document from the government of Canada that states certain things that I need to do, I shouldn't do, and those words are there. So how can we change when the policies haven't changed?
Yeah, thanks, Marvelous. You said it, everything, but I think for me it's about, in terms of raising awareness, if somebody says a word that you feel is discriminative or is not People First language, it's about pointing it out to them and also saying, this is why it comes across this way, this is why it's not right for you to use this language, and here is an alternative term for you to use. And I think Yvonne, you mentioned it earlier. It's about doing it with kindness, because oftentimes people are not doing it to harm or to be discriminative. It's just words that we've used over the years.
And I think it's just remembering this is ongoing, and terms will change over time as we get more knowledge, as we learn more, as we present, we're doing different things in the context of HIV. So in the early days, it was very much, about survival, whereas now it's about long-term prognosis and keeping people really well and good quality of life. So I think the language has to evolve, so we have to be continually open to that change. And just try and remember, sometimes when you're, presenting as well, you can get really nervous, and something you might not normally say, you would say. So none of us is perfect. We will all make mistakes. We will all get it wrong at some point. And it's just trying to remember that you need to, think about it. And if you can, next time, correct it. And I think that's really the key.
Can I add just something? I know we're talking about English mostly, but I know in my language, my sister is sitting there from Zimbabwe, and I think other countries too, these words can kill you. The words that people use are the ones that prevent people from even getting tested, from even disclosing. So I was just trying to see those words that you had put and trying to convert them in my local language. And I'm saying, okay, these are the suggested, but is it easily changed in my language? So maybe trying to think also, yes, we are talking at a global level, but at local level, because we are talking about people who are coming from their country using those languages, especially for us, some of us who work with immigrants. How are you, both the terms that they're using here, they're even thinking they're lighter than the terms that they were using back home. So trying to think, how do we, because we are global people, we have to think about globally, not just locally.
No, absolutely. I think it definitely starts with awareness and then just trying your best with what you know. So, yes, the language is super important. Another question we have is, what can we all do better? And I think we've mentioned in a little bubble there, for example, researchers, congresses, and people living with HIV. So I'll come to Yvonne because I know that with the People First Charter, you're doing quite a lot of work with researchers and congresses.
Thank you, Emma. And so I showed you a number of quotes from congresses and journals that are using People First language. And so we do have a website. It needs updating all the time because terminology will change. And it just has suggested alternatives for language that may be felt to be blaming or stigmatizing that has been reported maybe to the group. And the People's First Charter Steering Group is made up of healthcare providers and people with lived experience of HIV to try and ensure that we are covering as many bases as possible. So we're not going to be perfect. It's a first, attempt as an organization to do this, but we are getting more and more people coming on board. But it is something that will take time for language to change. I think if we think about autism and neurodiversity, that's a completely different thing now. And I think we are in that era where we have the ability to be able to change. And now is a good time to move the language forward because we have such good treatment, because people live very long lives with HIV, that we do need to address that language. Because treatment is great, but stigma is still a killer. And Marvelous said that. And I know you talked about it can kill you personally and feel awful, but it can kill by people not coming forward to test. So it is something that we do really need to address. So the People's First Charter has a website. If it's something you think your organisation would like to adopt, we'd love to hear from you because we really want to get it out there. We're on Twitter as well. So do please contact us because we would like more and more people and organisations and conferences to sign up and say we want to use People First language where we can.
And just other examples, I'm going to come to Angelina, of things that we can do, maybe small things that we can do better to make sure that we are making use of People First language.
Thanks. I think a lot has already been alluded to, but I think just continually raising awareness, continually producing resources, continually pointing people to where they can find that information, not blaming or anything like that, but we just have to keep raising awareness, and we also have to keep, as years go by and terms change, we also have to keep updating those terms.
For me, I think going back to the greater and meaningful involvement of people living with HIV, I also encourage those that when you recruit people living with HIV to be either research assistants or on your advisory board, before you publish, share with them the documents so that they can go through the document and see if there's something that's not sitting well, rather than publishing and then I pick it up and then we are not happy with the results. So I think just making sure that we are involved also in looking at and I'm doing my PhD myself. I'm trying to see at what point am I going to even involve. So sometimes academically, there's not that opportunity that for you to be sharing with community. So maybe us also who are in academia trying to talk to our supervisors, trying to talk to our departments on how can we change the language, because sometimes academia is the last to learn because we just want to have our degrees, want to publish, and we don't care what, as long as it's passed through. So I think we all of us have got a role.
No, absolutely, and I know at VIV we try to make sure we've got community review of our language as well as the content, so we're working on developing that further. But I think an example of trying to make a difference was seen today earlier on with, I think it was Dr. Cortez, who had crossed out HIV infected on an older article, and I think that's the way to go. It's like continuously changing and evolving and learning. And not being afraid to, if you get it wrong, you get it wrong, but, we evolve and we learn. Right, so I'm going to go on to the next, if I can. So this was the Slido results. I'm going to just go through some of these, if I can. So some of your responses have been absolutely amazing. So again, I totally agree with practice makes perfect. Exactly what we're saying is that it's a moving feast. I mean, as Yvonne was saying, that the terminology will keep changing, it will keep evolving, and we need to make sure we just keep practicing. Yep, don't be dismissive. Really great example. I don't know if the panelists want to comment on these.
I would just say, as a reviewer for journal articles, I understand that people maybe don't have English as a first language, and that's, I mean, I can't write a journal article in another language, so believe me, I'm really impressed that other people can. But if the language is not quite fitting with the People First Charter, I will return the script with a copy of the People First Charter and ask them to address the language, and that is what we try to do in HIV medicine. I know other journals are doing that too, because again, often the message they are giving is incredibly important. So I will review as normal, but just comment maybe on how the language could be improved. But I certainly wouldn't reject an article based on language. I would ask for it to be improved, and when it comes back, improved. If the main message of the article is, incredibly important, I would never reject out of hand purely based on language, particularly when I know it's written by somebody who may not be using English first.
Angelina Marvelous, any comments? Okay, I want to move on to the next. So we've talked a little bit about how we can educate ourselves, and Yvonne, you've already talked about guidelines, etc., and how we can make sure we update them. I just wanted again to ask Angelina, because I know that you've written quite a little bit about articles of language and changing. How do you educate yourself, and how do you keep on top of the changing times?
Exactly what we're doing today. Make sure I'm attending forums, make sure I'm reading up, making sure I'm speaking to other people, and I'm also part of the People First Charter. So constantly also looking at, because lots of people publish guidelines, for example, the WHO are in the process of producing, if I'm not wrong. So whoever is producing them, making sure that it's not just a one-sided thing, and we're not the only people who can talk about language. There are other people out there who are producing amazing resources. So I just make sure I'm keeping updated in terms of what else is out there and what else can I incorporate into what I say or write.
Thank you. I'm going to just give us, because I know we're running a little bit over time, so I wanted to make sure the audience have got time to ask some questions. So if anyone, if you want to put your hand up in the room, if you wanted to ask the panel any questions around person first language, it would be a great opportunity for you to do that now. Or yeah, any questions or comments would be great. Yeah.
So for people who I guess aren't in the sector as well, because you do have a lot of people that are working alongside but not necessarily are fully in the sector, what is the ideal way to communicate this message to them, as outside of like knowing the information? Because it's like sometimes it's people maybe know better but just are so used to saying things, whereas other people it's like a completely foreign language, so yeah.
I think I'll just start off by saying I think be non-judgmental, which was already mentioned by the audience, but I think, yeah, just having that non-judgmental approach that we're all learning is a really great start. But I'll pass on to the panel.
For me, if I'm asked for an interview, let's say by CBC or whatever, my ask before they even, I want to see the article before you publish it, because I don't want to be called a victim. If you don't want to show me, then don't interview me. I need to own it. And wherever I am going to use that language, I'm going to explain why I've used that language. So trying to also teach people, because sometimes the stigma, we see it in the media. So try to give them the right language to write, and why you are saying that.
I think you've just nailed it, Marvelous. It's about, you've mentioned the media. So the media are the ones who are going to report about the things that we know that we want to get out there. So social media, the TV, radio, whenever we, as you're saying, we're writing about HIV, whenever we're being interviewed about HIV, is making sure that we're also correcting the journalists, because oftentimes they're reporting things. So for instance, just this week, there was an article in The Lancet which talked about elimination of mother-to-child transmission. So we are going to get together, we're going to write a letter to the Lancet, not telling them off, but just saying this is the preferred language. So addressing things like that which happen with outside of the sector.
And I guess as a physician, if I'm referring somebody with HIV to another service, I will try and use language in my referral letter that I would hope my my fellow colleague would mirror. And that's what I really think is important. If I hear that language has been used that hasn't been appropriate, or if I see in a letter, I will just contact them directly and just have a word. And just say, actually, there's a better way to say this. There's a different way to do this. Maybe you weren't aware. So I would go directly to the person and make sure that it doesn't happen again to someone else.
Thank you so much. That's an absolutely fantastic session. So I've really enjoyed it. I just wanted to ask you, just from my own experience from the trans and gender diverse community, using inclusive and non-stigmatizing language has been something that we have been talking about for ages, and the sad truth is at the moment that we're seeing so much negativity and pushback against that. People labeling us as wokeism and all sorts of other much worse terms. And I'm just wondering, is that something that you are seeing? Is that something, that negativity, that pushback, that no, we don't want to do this, we're sticking to how we've always done it? Is that something that you're seeing, or are you seeing much wider acceptance of people first language in our field of HIV?
Can I just comment in the context of the BIVA, so the British HIV Association pregnancy guidelines, because we've updated our language, and actually locally we did that a while ago, so thinking about women and people living with HIV who are pregnant. And so our infant feeding statement, which we issued in 2023 to try and clarify between the difference between mixed feeding breast and formula feed with solids, we used breast and chest feeding, and we tried to introduce different language. So we were using birthing parent, and we didn't just use birthing parents, we wanted to make sure women were not excluded also, so we included women and birthing parents, and now we've simplified it to just women and people living with HIV or HIV in pregnancy. So we've altered how we approach the language to ensure we are inclusive, but we will not exclude anybody to include somebody else. And I think that's important too. And that's evolving. So we've gone already from birthing parent to finding actually that's way too clunky to using women and people living with HIV who are pregnant. So we haven't had pushback from the infant feeding guidelines. We suspected we might, but we didn't at all. And our pregnancy guidelines will be coming out and we'll be using exactly the same language. It'll be interesting to see what happens there. It was a great question, Kate. Thank you.
Paul?
Well, thank you for the fantastic panel and a very important conversation. And I'm a healthcare provider, and I do want to say sometimes you struggle with finding the right terminology. So I find this dialogue being very important. For example, to Yvonne's point, HIV exposed uninfected infants. I would probably start with infants, because what matters here is the human life, right? Infants with perinatal HIV exposure, but I would want to still use the word perinatal, which I know is still sensitive. But it's important to me as a pediatrician to differentiate the child who has perinatally acquired HIV versus sexually abused child, for example, or some other route of transmission. So it is sometimes a struggle. I just want to say that even on our end, I sit on HHS panel, so many members here in the room, and we go back and forth and we jingle this word, and having the input from the community is crucially important. And I would say for any terminology like that, it shouldn't be just adults only. I do think it's important we ask children and we ask young people. And to your point, Yvonne, as a healthcare provider, I was just thinking to your comment about the medical letters, which we sign as well a lot. And it could be just a standard blurb that could be added at the letter saying, this letter is in reference to the person living with HIV. These are the current standards of the language that we use, because they go to primary care providers, many of whom are not part of this dialogue. And I think we should just think of creative ways to educate it. And your session is a prime example. Thank you.
And 3 at the back.
Hi. Hi, very beautiful discussion. My name is Chilufia Kasanda from Zambia. I work with AGYWs in my work, and there are certain terminologies that I used in the HIV program. For example, it's intimate partner violence. This has been a very big debate with the people that I work with. One question they've been asking, what's so intimate about violence? Why should we actually continue using the word intimate partner violence? What are you doing mentally to the people that suffer the violence? So because we're having this discussion, I thought I should ask, what is your view regarding certain terminologies that are used in our programs? Thank you.
Thank you for the question. Let's check who in the panel would like to answer.
I don't have an answer, but I'm thinking, when we look, there's so many words that we need to change, a lot of words. But for the intimate partner, I don't have an answer.
It's a really, really good comment. But I guess in a way, when people were thinking about using intimate partner violence, was the fact that the violence was so close. But I agree. I agree. If you think about it again, I think I would just use domestic violence. But yeah, I'm going to have to think about that, and I'll come back to you. But it's a really, really good comment. Thank you so much for that.
No, that is, and I think you've shown that you're actually making the panel really think about this one, because, I mean, for me, I guess the difference is what was the type of violence? Intimate doesn't tell you anything. So was it sexual? You know, was it physical? What was it? And I think I think you're absolutely right. I think intimate just masks something and almost not condones, but it suggests complicit. You know, you're with somebody. It's intimate partner violence because you're with them. And actually, it's just violence, and then we need to categorize what kind of violence it is. So I think you're right. I think you're absolutely right.
And this has been a really interesting discussion, but I think we've only got time for one more question. So if it depends on who's been longest. Okay, we'll take number 3.
Hi, my name is Jessica Marie Fox. I am Washington, D.C. location. First, thank you so much. This was amazing. I just wanted to get your thoughts on, and I know we covered a little bit of it, but in regards to like scholarly writing, I'm a student in a DNP program right now, and I recently had a dissertation returned with comments made on my glossary, which I had essentially flipped for person first terminology. So as we've already, again, discussed a little bit about how, you know, we have to work our way up and build it to these institutions and these like educational institutions and such. And I will say, and it's unfortunate to have to say this, but as a female in scholarly writing and as a nurse practitioner, you know, there is this pressure to include like proper medical terminology in our writing. So how would you recommend that we go about like having a disclosure or disclaimer at the forefront of the work that you're writing, or just kind of plow ahead with this person first terminology throughout the work?
I mean, I think that's a great comment, and I'm really sad that that's happened to your work, because I'm sure your work was brilliant, and the fact that you use person-first language is really exemplary, so thank you. For me, being medically correct and person-first is they're not mutually exclusive. You can be really medically exact and clear, and you can still use person-first, person-centered language. So I would send them you could just attach a copy of the People's Charter, because I do think the more of us that use it, it's something that can become standard practice. Yes, it's a small movement at the moment, but you know, we can work together to actually make this more widespread, because it doesn't apply only to the context of HIV. It works in all sorts of contexts, such as diabetes, you know, weight management. There are so many different arenas where we need to improve language. So I think the more of us who use it, and the more of us who advertise the fact that there is a different way to speak, I think the more people will learn, and that probably shows that actually the people who are marking your text were probably a little bit out of date.
Thank you. Thank you so much for all of your questions and your participation. I'm going to try and summarize and close in about 1.5 minutes, which wasn't planned. It was about 5 minutes I was going to have. So we're going to talk about tips for how to use people first language. I was going to ask the panel, but I think I'll just summarize quickly and sort of say that we've got lots of resources available to us that we've highlighted, so always just go and check what's the latest updates. Try to be non-judgmental when you're educating somebody about the correct terms to use, and also just being open and, you know, open to learning, open to changing, and open to adapting to new things and new ways of using language that is for the person, not necessarily for our selfish needs to get across data, etc. So we also wanted to, because you've been so passionate about this, make a pledge or ask you to make a pledge and think about the fact that it starts with us. I know none of us in this room are intentionally wanting to use non-people first language or to reduce somebody to a term or an acronym. So it starts with us. So what would we like is to ask you if you would pledge to try to use person first language or people first language, and just write down what you think you would like to do, what one thing you would like to do, and those who are online, if you can write it in the chat, that would be great. And the last thing I would ask you to do is, we ask you to write in your little speech bubbles how the terminology of non-people first language will make you feel, and to reduce that negativity, we ask you to tear those up, and then just tear them up, because we just want to get rid of those old, outdated terms and negative terminology in a nice ritual acting. Thank you so much. And just to add again, our artist has completed her some interpretation of our conversation, so we're going to bring that up to the stage. Again, this is going to be available, so thank you so much, Katia. If you do want to have a copy of this email to you, please make sure you give us some feedback. In the feedback form, the top answer is going to be your email address. If you want to remain anonymous, don't put your email address on. So with that, I would like to thank you again. Thank you for your participation. I'd like to thank my lovely panelists for taking part and giving their knowledge and experience. Thank you so much, everyone. Thank you for your time.